All right. Well, good morning, guys. I'm gonna go ahead and get going. I'm Greg. For those who don't know me. All right. So we're gonna talk a bit about just basics of placing pedicle screws, and we're gonna do it in the open environment and then also in the MIS environment, fluoro-based. Just a few things on anatomy, especially as it relates to um, placing pedicle screws in the open setting. The pedicle anatomy differs a little bit in the thoracic versus lumbar spine, and a few different things to make note of in the open setting is that you always want to make sure that you have your exposure adequate in order for you to be able to adequately place your screws safely. A couple things that you'll always want to look at is the superior articular process, and that will get your starting point as far as your medial lateral orientation is concerned. And you always want to have the contralateral transverse process dissected off as well, as that's likely going to be the best way for you to orient yourself in the sagittal plane. So those landmarks are very, very consistent. So again, the superior articulating process of the pedicle that you're cannulating, and then the contralateral transverse process. And we'll talk about why those are so important. In the lumbar spine, things are a little bit different. Couple things that you're typically wanting to understand there is more the interaction between the pars interarticularis and the transverse process. So in these, when you're doing your dissections, you just want to make sure that you see the lateral border of your pars, as well as understanding the superior and inferior margins of your transverse process, as that will also determine your starting point. As far as your sagittal orientation, in other words, how to aim your screw, you're going to go, as with the thoracic spine, to the contralateral transverse process. So you want to have those anatomic landmarks pretty well dissected free so you can better understand. Now, if you're operating on older patients that have a ton of arthritis, you guys that have worked with me so far know that I like to take the inferior articulating process of the cephalad level off, because that helps me orient myself. But the other thing it does, it really cleans up the spine well and makes it actually look like a spine. So before I put screws in, usually with that ultrasonic bone scalpel, we'll take the inferior articulating process off. Then the other thing you just got to make sure, because the pars is an important structure that guides you in the medial lateral orientation, because you want to know where the lateral pars is. You have to be a little bit conscientious of arthritic overgrowth, because that does happen where there'll just be a ton of extra bone around the pars. And if you don't kind of clean that off and get a better sense of what the actual true anatomy is, it'll usually push you lateral. So you kind of want to know exactly where that interaction is between the superior articulating process and the transverse process, and then also the pars interarticularis. The other anatomic considerations is just understanding your angle in the axial plane relative to the level that you're going to be instrumenting. That does change throughout the lumbar and thoracic spine, and having an understanding of that will be important for you, where you'll see the trajectory go from very lateral to medial at L5 and S1, to actually medial to lateral at T12, and then going back again to a more lateral to medial as you go up the thoracic spine. And then again, just anatomy, just having good relational anatomy, I think is really important, that you know where things are. Something to always keep in the back of your head, like the bad area is medial and inferior. That's where you don't really want to miss. And so if you're going to miss, you want to miss high and lateral. So that's the ticket there. So a couple other things, just like pedicle shape. The shapes do change as you go from the low lumbar spine to the upper lumbar spine. I mean, you'll see this a lot. So I always encourage you guys, whenever you're having a case where you're doing pedicle screw instrumentation, is to look at the CT scans, that can actually be really helpful, and you'll assess these patterns even while you're looking at it, and you'll see the shape of the pedicles actually change based off of their anatomic location, becoming very vertical in nature up at L1 and oblique down towards the low lumbar spine. Just a little thing to continue to remember because it will have some effect on pedicle sizing and things like that. Again, this is looking at the transverse angle or the axial angle as it relates to different levels of the vertebral bodies, and you'll see that at L5 you have the most lateral to medial trajectory, and they're upwards of 30 degrees, and that goes down to about 10 degrees right around L1. And then at T12, like we talked about, there's a pretty sharp angular change that has a more medial to lateral trajectory. And then basically slowly over time, as you work your way back up to T1, the lateral to medial sort of trajectory once again becomes the more common angle. Now, you're working through a tube, so there's a lot of flexibility on these angles. In other words, if you think about putting a screw through a tube, you can start at one spot and without having to make these dramatic shifts in your medial lateral trajectories, or in how angular you are. For instance, at T12, how often are we really putting in screws from medial to lateral? That's hardly ever happening, right? We're usually going straight in, or maybe even a little bit lateral to medial. So the main thing is that you understand this chart is that when you're placing the screws and you're finding resistance to where you're putting your probes, this is a really important chart so that you can reflect on, okay, if I'm going to miss at this level, what's the most common miss? And for T12, for instance, it's much more common to miss medially towards the canal because of the natural trajectory of that pedicle. So those are kind of the main takeaways there. Same thing with like L5 or T1. It's pretty hard to miss medial because you have to be you have to be at a crazy angle, and usually like at L5 you can't even get to the angle to miss medial because it's so hard to get your hand to go out lateral like that unless you're doing it minimally invasive. So again, exposure is key. It's really, really important. I like to expose the superior articulating process in most of the spine where I'm doing the open work. And that usually for me means removing the inferior articulating process, and you can do that with a Misonics or with osteotomes or Kerrisons, as you see here. Usually something like a Misonics just makes it simple, and you're not using any force against the spine. You also want to expose your transverse processes as well as kind of having a good understanding of where your lamina are. And obviously removing that inferior facet then allows you to have a real clear view of the superior facet, which then is key to getting your pilot hole. So if you think about this, the superior articulating process has a very, very concrete rule associated with it, which is you want to know where the 50-yard line is on the superior articulating process. If your starting point ends up being at the level of that midline of the superior articulating process or medial, you will without a doubt have a medial breach. So that's the big takeaway from why we want to know where the lateral SAP is and the medial SAP is, why you're exposing that lamina and you're exposing the pars. Because if you understand that alignment there and you always start lateral to the midline of that joint, you will have a much lower chance of having a medial breach. If you're in the lower thoracic spine, you guys will hear me talking about that ridge that exists on the transverse process. That ridge is oftentimes a little bit of a key to finding your way into the pedicle. Frequently is the actual starting point because that ridge does seem to move in the same cadence that I'm going to show you here. But from T10 to 12, kind of something to think about is just midpoint of the transverse process. and going towards the starting point, which being on the lateral half of the superior articulating process. That's typically your starting point. From T7, 8, and 9, it's the, we say, top of the line, and by that mainly looking at the top of the line of the transverse process. It ends up being on the top of it, of the TP, and again, that ridge is typically your friend as it finds its way towards the pedicle. So at 7, 8, 9, you're moving cephalad up on the transverse process, and then keep maintaining your relationship on the SAP. That's going to stay consistent. 3, 4, 5, and 6 are in the top third. And then at T1 and T2, you come back caudal and you're right back again to just about the middle of the TP. So there's a little valley underneath there in a lot of these cases where you can find your starting point to be. Again, the SAP relationship remains standard. For the lumbar spine, there's sort of two ways to think about it. One is the intersection of the pars and the transverse process, and usually there's a little bit of a ridge right there, and you go right into that ridge. The other way to think about this is about the halfway mark. If you mark out your transverse process, cephalad and caudal, about the 50-yard line from the superior inferior direction is typically where the starting point will be, and butted right up against the bony ridge of the lateral facet. This is sort of that, again, that transverse process method where you say, okay, I have my pars here. This is my TP. That's where I'm aiming at on the other end, and I'm going to put my screw right there. So that's usually, in general, what I do. The one that's a little bit different is L5. I think L5 tends to, I like to use this methodology a little bit better because the starting point's usually a little bit lower at L5. So, the other thing is, like, people always say, like, how do I aim to make sure that my screws are parallel to one another? And I think a lot of you have heard me talk about, like, I don't care. I like my screws to look the same. It's not that one side is right or wrong. In other words, the right side of the table versus the left side of the table. No, it's more that you want the screws to look the same. So basically, if you have the left and the right side aiming at the same point, then they will typically very nicely align on X-ray. So what this means is if you're gonna put screws in, and this is that transverse process method I was talking to you guys about earlier, where you're really aiming towards the contralateral transverse process. It's in a deformed spine. The sagittal plane sort of dictated by understanding where the other side is, because you're just going to take your gear shift and aim it at the other side. And so you're working on your medial lateral trajectory based off of your SAP and the rotation, and then the contralateral side going to be based off the transverse process. And in general, this works really nice. So the other thing it does is it allows for there to be a very nice cadence of your screws. So again, visualizing the medial border of the SAP is important, and then you can triangulate towards it because when you're putting the screw in, if you look at the green arrow, you're typically starting a lot more lateral than this medial mark of the pedicle is, right? And so if you're triangulating towards that medial border of the SAP, you'll pretty well put your screw in a good medial lateral trajectory, and that's kind of what we're talking about here. And typically, most gear shifts are marked for depth, so you know if you're in 20 or 25 or 30. Just realizing that after about 25, you're in pretty good shape. Other ways to do it is with the lanky probe, and the lanky probe is one that has a curved tip to it, and this is the way Larry will teach it, is that for the first about 25 millimeter or so, you have the tip of the lanky probe aimed laterally. The main reason there is just that you don't want to err in the way of the canal. And then after about the 25, you come out, you palpate it, you switch it by 180 degrees and orient it medial, and then place your probe all the way into the vertebral body using that methodology. In general, this works nice. As you can see, I'm sorry, these are some of the things that you're trying to avoid, right? If you go too medial with this, and if you have it in the lateral trajectory the entire time. So having it in a better trajectory is obviously critical, and then flipping it 180 to get it in. And this is the sort of the Sentinel paper that he wrote on that. Again, feel all four walls, but the medial and inferior are most important. So if I'm spending any time, if I'm worried about anything, it's typically the medial and inferior borders that I'm spending a little extra time on. And then a couple of things to realize: if you're in a kid, or if the tip of your pedicle probe is really small, then if you're not careful, your ball tip probe, the actual ball at the end of it, could actually be larger in diameter than the pedicle probe itself, the tip of it. So you just got to make sure that you know the instruments that you're using to be able to give you the confidence that you need, because it could bottom out and you think you're fine, but there may be a problem distal to that if the ball tip is bigger than the channel that you created. And then depth could technically be inaccurate as well. If you have pencil thin pedicles, this will happen in patients where you don't have any cortical margin whatsoever. And these patients, a lot of times, are doing in out in screws. You'll hear me frequently say critical screw, yes or no. If it's a critical screw, we'll do something like this. If it's not a critical screw, we'll skip it. So this is why I like to plan these cases ahead of time when you're looking at the CTs, just so you're aware if there's a spot where the pedicle channel may not be good. In general, like, I don't cannulate these and I don't use in out in unless again it's like in a critical area, or you have like 6 of these, which happens as well. If you have someone with like horrible neurofibromatosis and you have pencil thin pedicles, you may have to go in out in, or figure other types of fixation. And there are plenty, whether it's sublaminar wiring or bands or hooks. There's lots of other options as well. So don't feel like you're kind of locked into a corner to do one thing. And then on the again, type C and D pedicles, this is what you're doing. You're going lateral to the pedicle and then taking the probe and turning it into the vertebral body, so you get all the way in. When you're done, you should have pretty good harmony of your screws. What this means is most of the screws should be aiming at each other, and you should be a nice cadence of the screws being, neutral at one area, going to be more medial, and then swinging back out to being in their normal anatomic alignment again. And if you're on the convexity, then you should see the opposite, where they start nice and medial, they look like they're going more lateral, and then they go medial again. In the sagittal plane, you want them to line up as best as possible, and you're looking in the sagittal plane mainly for length. So this is what you're bringing. You're bringing your fluoro, and you're making sure that length is not an issue at any of the places where you put them. So if they're not in harmony, then you can usually figure out what's going on just based off of the pedicle trajectories. So a lot of times when there's misses, they're typically lateral, especially if that screw is long. So if you see that the screw on the AP looks okay and on the lateral looks really long, there's a good chance that screw is medial. The flip is also true, that if it looks on the AP that it's fairly medial, yet when you look at the sagittal, when you look at the lateral, and the screw is really short, that's a bad sign, because that probably means in the canal. So those are ones that you definitely want to check. If you look at, if you have a couple of screws that look like they're off, always palpate the most off one, because it'll tell you if the others are off as well. Just a quick little setup. So if we scoot over to the fluoro-based screws real quick, I'll try not to take too much time going through this, but a lot of times you're just having a regular Jackson table or a fluoro table of some sort and a C-arm, and that's typically what we're using. I'm going to use this animation just so that we have nice pedicle anatomy, but what you're doing here is basically trying to figure out where the lateral border of the facet is, or the lateral border of the pedicle, because that's going to be frequently where your jamshidi needle actually enters into the bone. Now, depending on patient size, my usual is somewhere between 4.5 and 5 centimeters from midline is where you're going to make your incision. And that stays pretty darn consistent. If you're doing a long construct, say up to like L1 or T11 or T10, then you're going to want to narrow that distance from midline because those screws don't need to be in such a harsh lateral to medial trajectory, and you won't be very happy with that. Because you'll be fighting skin at that point. So in those cases, a lot of times the screws up in the low thoracic, upper lumbar spine end up being about 4, and sometimes even 3.5, depending if it's a really small person, centimeters from midline. Again, using what we know about the anatomy and safety margins. A lot of the jamshidis that you'll end up using do have a depth with them, so you can understand how deep you are. In general, I like to when I skip my starting point, this would be like a normal starting point. Again, here I'm trying to go parallel to the end plate, and I want both screws to be parallel to the end plate so that when we're done, the screws look pretty. The other thing on here is that, again, remembering the pedicle trajectory, knowing that at L5, you're going to want to have your hand dropped a little bit further than you do when you're going to the upper lumbar spine, which is the cadence will slowly be to be raising your hand more perpendicular to the floor. The other thing is always make sure that you have perfect AP imaging. Having perfect imaging is critical to getting these screws in appropriately. Don't accept mediocrity. If you're having a hard time getting the AP, just swing to a lateral real quick, get a good lateral, see what the orientation is, and then go back to your AP and have it lined up that way. So it's a quick little trick to make sure that you're manipulating the C-arm in the correct direction. All right, so I like my screws in general to look like this. In other words, when I'm in about 20 millimeters with the jamshidi, I like to be close to the middle of the pedicle because that gives me great confidence that I am not going to be breaching anything. Now, obviously, not everybody has an 18 sorry, I shouldn't say 18, but like has a 1.5 centimeter wide pedicle like this guy does here. But if you have the space, and again, you just check your CTs on this, it's nice to have this trajectory here. This gives me great confidence that the screw is going to be in a really good spot. When it looks like this, I'll typically not even go to a lateral. I just go ahead and put the screw in. Because I know I'm in good shape. If you're worried at all ever though, you always swing to a lateral and just remember the relationship between, okay, how deep am I in, and then where am I at relative to the medial pedicle border? Because if I'm in beyond 20 millimeters and I'm not to the if I'm in only 10 millimeters, I'm already at the medial pedicle border, the chance of you breaching is going to be really, really high. The problem with a lot of the jamshidis is that you lose the tactile feel, right? Because we're using mallets to do what we're doing. And so while you have soft hands doing that, depending on bone quality and trajectories and how many passes you've have made through there, it's pretty common that you lose a lot of the important haptic feedback for safety. And then placing it the rest of the way, you'll place it into the vertebral body, and then per usual, placing a K-wire and then the screw over the K-wire. For S1 can be a little bit tricky. Here you can see, wanting to make sure that you get the superior end plate of S1 as clean as possible. And then the other thing, just understanding your sacral promontory and where you're going to be aiming. Same thing here. Sometimes it's a little bit more difficult to visualize the superior end plate of L5. A lot of times there's an inner body in here already. So if you're doing an ALIF, an easy way to cheat is just to see the surface that's up against S1 in a clean fashion. So like if you just line up the C-arm relative to the inner bodies, a lot of times that's a little trick of cheating the system there. Again, on these, in general, I like to start low in the pedicle and then aim a little bit higher up towards the top of the pedicle. The main reason there is I'm trying to get as long of a screw as I can, and I want to get as close to that sacral promontory as possible. A lot of times it's good to use lateral fluoro here because it will allow you to guide and direct you on your way in. And then again, we want to try to get that to the sacral promontory as best possible. It's possible to do bicortical screws in the percutaneous environment as well. Although, I mean, it's got to come with its share of risk. So I use that cautiously, but you would basically just breach it on the lateral and then place the screw over the wire. You just have to be careful because that wire will want to migrate anteriorly into the abdomen. So other way to do it is to know that you're at a certain length and just place a screw that's slightly longer than what it measured with your jamshidi. Usually that bone is going to be weaker than the screw that you place, and so you're able to breach the anterior cortex with the screw itself. But those are a few little pearls there to keep in the back of your mind. So here's just a case, 62-year-old guy, had an L2 fracture a long time ago, had back pain and leg pain, did multi-level laterals on him on one day. This is him post-op day 0, doing a post-op check, and then did on the second stage, did an ALIF at 5-1, and then did percutaneous fixation. And here's how we think through that, just making sure before we get started to have an understanding whether he's aligned or not. That depends on how we're going to change the intraoperative strategy. If we need to do any reduction, he's already lined up, so all we really need to do is lock this guy in place. So again, here you're targeting the lateral wall of the pedicle. It's nice to do these simultaneously so that you're able to see where you're aiming, make sure that they go into the same spot. And when you're using jamshidi, you can do them simultaneously like this, which is in general nice. So then you work your way up the spine. You're just doing it level by level, taking your time, getting your screws in. Obviously, if you're using navigation, et cetera, it's going to be fairly similar to this, with the exception of not having a big, bulky C-arm in the way. And then we'll just march our way up the spine from L4 to L3, L2, L1. Same technique all the way up. And you see us injecting a little bit of like flow seal or Surgiflow into there. The main thing there is just to kind of coagulate some of the bleeding that can come from the pedicle. Again, the wire goes in and then end up placing the screws over the wire. At each level, though, especially in deformity, you want to make sure you have a good clean look at the level. So keep rotating the bed or the C-arm to make sure you have a good clean view. Next, if you're using this methodology, you'll tap and then place the screw over the tap. So I'll usually do this level by level. So we'll tap and then place a screw and do that again, level by level, get all your screws in place, and then check your AP and lateral, make sure that you're happy with where you're at. The other thing is, obviously, at this point, just make sure you check your lateral for alignment that you like where you're at, because this is the only time that you really get to change it. Then this is using intraoperative rod bending, so you're just targeting all the pedicles, or I should say the tulip heads, where they are in space, mapping them, and then that generates a view on the back table what it looks like. You can then make a modification to that plan, say, you know what, I want to correct this by 50% or something like that. And so you can see that's what we did there, is that we did a 50% correction, and then that shows you that's doable. So we'll build that into the making the rod, giving us the rod coordinates, which we then take those coordinates to the back table and then bend that rod. So here's where we're cutting it. And then coordinate by coordinate, you basically make your rod. Then this is placing the rod, again, level by level, making sure that you're in all the different Phillip heads. Usually sits pretty good. And then placing your set screws, reducing the rod into the screws, and then checking your T-square again, make sure you didn't alter anything. Check your lateral, make sure you're happy with the lordosis that you created. Here's your final intra-op and final post-op. So cool. Questions?
Hey, Greg, that was a great talk. Can you speak to the point of using sort of the beveled jamshidi needle
Oh, sure.
with avoiding over medialization?
Yeah, so the bevel on the jamshidi needle is a little bit like a lanky probe in some ways because it gives you a little bit of directionality to where your tool is going. So the bevel allows you, and I should throw a slide in on that, Don. Take a note. Is that the bevel allows you to let's say you're going in and you're aimed a little too medial, right? You can actually take the bevel, turn the bevel lateral, and then all of a sudden the bias of the jamshidi needle will be to go lateral, and so you can tap that for a while, and it'll literally change the trajectory of the jamshidi. And then once you're like ready to go medial again, you can flip it 180 again and go medial. But the same holds true if you need to go a little bit more superior or inferior, or even superior and medial or something like that. You can change the bevel to kind of help guide you as you go into the pedicle.
Yeah, thank you. That's a great little pearl for the trainees, you know.
Awesome.
And then one other quick question. What's your experience with obtaining fusion? On that case, you had the inner body, so you have sort of the fusion anteriorly. Do you have any pearls for posterior fusion on those? I know this is a pedicle screw talk, but it's, I think, a good question.
Yeah. So I think there's a difference in opinion on this. I feel like if I'm putting in a implant like that, that I'm off the hook anteriorly. If I'm putting in a lateral or an ALIF, I'm off the hook for a posterior fusion. So anywhere that gets in their body, I'm not taking the time to drill out facet joints and things like that. And I have to admit, like the number of non-unions you have doing that is very, very low. I think part of it is that you're actually not disrupting the anatomy, which means you're leaving the inherent like arthritic, stiff joint, arthritic and stiff, and you're just working around it. So there's probably some inherent stability in those joints to begin with. And then you're just getting all your fusion anteriorly. In areas where I don't have that, then I will actually take down the facet joint. And that typically, and I actually take the facet joint. I don't go in there with a little burr and just burr around stuff. I'll go in there with an osteotome or Misonics and take off the inferior articulating process, clean off the cartilage, and then usually I'll stick just a little piece of BMP in there along with some bone graft. Usually the same facet that we took out, we'll grind up and put it back in. But that's almost everywhere I do it. Juan talks about, Uribe talks about in the thoracic spine not doing anything. He just instruments it without fusing it. So not sure if that's the smartest thing, but that's certainly what he does.
Awesome. Thank you.